the Evergreen Media Network Studios, brought to you by Evergreen Media, creating cohesive marketing campaigns. Evergreen Media in Vero Beach.
Okay, good afternoon, everybody. This is Dr. Brett Haake. I'm here with my wife, Dr. Felice Haake. This is episode 2 pertaining to a functional approach to the thyroid. And it's been a little while, so we kind of wanted to go over a couple of the high points from the last episode. So Felice, just for the audience's sake, give us a bird's eye view of exactly the way thyroid physiology works. Just a simplistic version of how thyroid physiology works.
Okay, so that's loaded. We did an entire podcast prior to that.
Just a summary.
But so to summarize, so your thyroid is sort of known as the master gland, and we used to call it that in medical school. It was called the master gland of the entire body. It's really important for all metabolic function in the body, from your brain function to your temperature control, your heart rate, ability to burn calories. So when people talk about metabolism, they're often really actually talking about their thyroid, mostly. So from that perspective, thyroid works at a glandular level. So it's a hormone. It's a part of the endocrine system. And it's signaled, and I can go through the pathway very briefly, but it's signaled from the brain, essentially. So the hypothalamus secretes a substance called TRH, thyroid-releasing hormone, which then tells the pituitary gland to release TSH, which stands for thyroid-stimulating hormone. And then that then tells the gland, the thyroid gland, which kind of sits anterior to your windpipe in the neck area, it tells it to secrete thyroid hormone. And the two that are secreted by the thyroid gland are T4, an inactive thyroid hormone, and T3. The majority of the thyroid gland produces T4. And then peripherally in the tissue, it needs to convert to T3, which is the active form. And I will also say T4 can convert to reverse T3, which we're going to get a little more in depth this episode on that.
So let's unpack that a little bit. But before we start, typically the conventional approach to looking at the thyroid is that typically what we do in the conventional setting is that your doctor will look at T4 and look at TSH. Mm-hmm. And the problem with that, like we talked about last time, is that T4 is the inactive form. And when T4 or T3 isn't high enough, your body will respond, your brain will respond by making more TSH. And typically when the TSH goes, it depends on what lab you're looking at, but typically when the TSH goes above around 5, we say that your body is low thyroid or hypothyroid. What is the problem in your mind with that methodology?
Okay, so you're correct. Most doctors will check a TSH and a T4. A T4, if you're lucky, to be honest. A lot will only check TSH, which is really ultimately supposed to be a screening test. That's really what it's supposed to be. And I found this out recently. I never knew this. Do you know when the laboratory TSH, when it was available, what year? It was in the 70s. And so prior to that, how did we test for thyroid? We actually talked to our patients and listened to them. So it was very symptom-based, which we have completely gotten away from.
Interesting.
Yeah. So in any event, so I'm sorry, what was your question again?
Well, so it's okay. So getting back to it, the problem conventionally is we look at T4 and we look at TSH. And so if the TSH goes over 5, then we say, okay, well, you're now hypothyroid and we need to give you thyroid medicine. And typically the medicine that we use on the conventional side is a medicine called Synthroid, which is T4. T4 is the inactive form. As we get older, T4 doesn't convert as robustly into T3 because what is necessary for that to happen is an enzyme called deiodinase. And oftentimes we don't have as much of that enzyme as we age, so we don't make as much T3. And when we give the Synthroid, that will oftentimes suppress the TSH. And so then we follow that treatment up with a measurement of the TSH. If the TSH has now been decreased, we say, okay, you're therapeutic. And the problem oftentimes with this methodology is the patient doesn't actually feel better. And so leading into that, let's talk about so T4 converts into T3. We said that T3 is the active form. And just for the audience, T4 is thyroid hormone with 4 iodines. T3 is thyroid hormone with 3 iodines. The enzyme that converts T4 into T3 is an enzyme called deiodinase. So it just removes an iodine from the thyroid hormone. But it's the T3 is the active form. So to lead into that, what are some things that T3 does in the body to maintain health?
Okay, so and just to go back to your question, essentially, what's the problem with just looking at TSH and T4 is that we don't actually know what the active hormone's doing.
Correct. Right.
And if we don't know what the active hormone's doing, we have nothing. And the active hormone's sort of the key to the engine. And if you think of thyroid as an engine, T3 is very much the key.
Right.
Reverse T3 being the blocker, sort of a pin in the keyhole.
Right.
So T3, I mean, it's far-reaching. From brain function, clarity. I mean, I can't tell you how many times I've heard of a patient, or I've had a patient come to me and tell me, "I'm tired. I'm cold all the time. I'm gaining weight. I can't think. I feel depressed. I have lower mood." And then they've come from another physician who's placed them on all these medications that are trying to, kind of put a Band-Aid on those symptoms, like putting them on ADD medicines or, giving them an antidepressant. I'm not against those things for the right reason. A lot of times you're giving it to these people and all you had to do is really correct their thyroid. So, T3 is very important in regulating temperature. It's very important at regulating your heart. Okay, so low thyroid is often associated with, very low thyroid is associated with congestive heart failure and even coronary artery disease. So there's a lot of actual conditions that, a low thyroid can present with. So T3, I mean, it's everywhere. It's in every single tissue, and it's important for all metabolic function.
So just to summarize, what are some things that patients should be looking for when they go talk to their doctor? And what are some things that maybe doctors should ask or patients should think to ask their doctor about to get them to check not just the TSH and the T4, but also the reverse T3, which we're going to talk about here in a little bit, and the T3? Like, what are the common symptoms of feeling of being low thyroid, or what we call in our functional medicine clinic suboptimal thyroid?
Right. And for the sake of this podcast, we're really just addressing low thyroid because that is way more prevalent in society than high thyroid. But low thyroid symptoms are going to be fatigue. And I can speak personally from this. I have low thyroid, as I mentioned in the prior podcast, but it's going to be fatigue, and usually pretty extreme fatigue. I mean, you're very tired even after a good night's sleep. They're oftentimes cold, not always. You don't have to have all these symptoms, but they often have cold extremities, cold fingertips, cold toes. They sometimes have constipation, so there's some bowel dysregulation as well. They're slower, they're not as quick. Cognitively, they feel just in general like lethargic, lower motivation to do things. Those are usually the complaints. Sometimes even that makes them feel depressed. They may not be actually clinically depressed. They just feel depressed because their thyroid is low functioning. So those are kind of some of the most common symptoms. Weight gain's a big one. And the classic low thyroid patient, because I see them all the time, they cannot lose weight. I mean, they eat right, they exercise right, they're doing everything right, but that scale does not budge. And it's very frustrating for them.
So maybe a common example might be the 50-year-old perimenopausal female who you've now determined to be in menopause. Maybe she started menopause 6 months ago or a year ago or whatever. You've replaced the hormones in a bioidentical way. Maybe you found that she was fairly insulin resistant, so you got her low insulin, low inflammation, recruiting diet on point. You've got her doing resistance training. You've got the stress reduced. You got her sleep under control. She's sleeping better now that she's on progesterone. You've got, you basically have addressed the insulin resistance. You've addressed the cortisol, maybe put her on an adaptogenic herb, and she still can't lose weight. And that patient, you're looking at her and you're saying, okay, the TSH might be, as opposed to 5, it might be 2.5, and the T3 might be, as opposed to, I think our upper limit of normal in our lab is 4.2, maybe it's 2.9. So they wouldn't meet the classic definition of, okay, they're hypothyroid, but they're still suboptimal. And those are the patients that can't lose weight. They're doing everything correctly, and then you just tweak the thyroid just a little bit, and all of a sudden they're losing weight. They're feeling better. And then what are some of the other side effects maybe that you don't see from really optimizing the thyroid.
Well, just to piggyback on that, it really is sad that it gets missed so often. I mean, there's just so many patients who will come in with all these, symptoms, and it gets completely ignored. I mean, to the point that even prior to the TSH lab being available to us, we actually used to give T3 to depressed patients. So it's really a problem. And part of the problem, and I think it's worth repeating from our last podcast, is that we overly rely on these reference ranges, which is what you were just alluding to. The upper limit of TSH being 4.5 on a Quest lab reference range, but yet a patient at 2.4, 2.5 kind of gets ignored by the conventional doctor. No disregard to the conventional doctor. You and I were those doctors, and we were not trained properly on thyroid. That's the bottom line fact. So these people kind of get shoved to the side and ignored, and they're feeling horrible. So it would be nice to go back to prior to the 70s where we actually listened to people's symptoms.
Boy, you hit the nail on the head. And we've experienced a lot in our clinic, in our functional medicine clinic, sitting down with patients. And there's times we have our intake, we have all the questions that we want to ask, our history, our physical examination. But sometimes the patient comes in with a whole list of things in a notebook, and sometimes our job is to sit and listen. And it's so important as a physician to sit and listen. The other thing I wanted to say is I think it's interesting. One of the benefits of optimizing the thyroid, and we talked about this on previous podcasts, is the ubiquitous aspect of insulin resistance and metabolic syndrome in our society. I think I recently read a stat that 70% of all American adults are overweight, and I think it's 50% of all American adults are obese. And so with that is this ubiquitous insulin resistance. And we talked about this before, but one of the benefits, one of the advantages to optimizing the thyroid is it helps with reversal of insulin resistance. And if you think about vascular disease and coronary artery disease, which we've talked about before, and atherosclerotic peripheral vascular disease as being a function of oxidative damage, inflammation, and ApoB particle burden, by minimizing that insulin resistance with optimizing the thyroid hormone, we can actually reduce a lot of this inflammation, a lot of the oxidative damage. And I think you had it written down here, one of the other benefits to optimizing T3 is you upregulate the LDL receptor in the liver. And so if you're having problems bringing down the ApoB particle burden or the LDL cholesterol in the patient, one of the tools in your armamentarium is to optimize their thyroid. And that cholesterol panel should start to at least look a little bit better. It may not be the end-all, the be-all as far as optimizing the patient's cholesterol, but it certainly should improve it.
And actually, hyperlipidemia or cholesterol abnormalities should prompt a physician to look at the thyroid instead of just jumping and trying to treat that LDL or lower that LDL. Back in residency, we had a really wise preceptor. So in residency, especially family practice residency, I know you did a different type. We have clinic. Okay. So we have clinic days. We have our own panel of patients. And then, as you progress through residency, you see these patients. If you have questions, you go back to the preceptor room where all the attending physicians sit, and they're there to answer questions. If you went back there to discuss a patient, and one of our preceptors in particular, if you didn't, and you told him that they had a high LDL or an abnormal cholesterol panel, and you hadn't checked thyroid first, and you were just going to treat it with a statin, you were in trouble. So, that I learned that lesson pretty early. So that's kind of conventional knowledge. Why aren't we doing that? I can't tell you how often I have actually fixed somebody's thyroid or put them on thyroid treatment medication, and their LDL goes back to normal. Their cholesterol panel improves just from that. So it really is, you have to kind of look at all the little spokes that, thyroid pokes itself into.
Well, and you bring up a great point, spokes, because this is going to lead into my next point is, so as part of our functional medicine clinic, one of the themes that we talk about is this idea of integrative medicine and this idea that all of these different systems work together. And so if you look at the number one killer of both men and women in the United States and the world, that being coronary heart disease, and that's a function of oxidative damage, inflammation, vascular immune dysfunction, and ApoB particle burden. And if you look at optimizing the thyroid, What does it do? It can reduce your ApoB particle burden by upregulating the LDL receptor at the level of the liver, and it also reduces the insulin resistance, which is a big player, a big driver of oxidative damage over the long term. So all these things are interrelated, and to your point, it starts with the old-fashioned sitting down and listening to the patient.
Yeah.
And it's okay. We all realize that your job as a physician is to interpret what they're telling you and try to understand what they're saying in terms of, you know, the converting that into some type of medical knowledge. And they may not always say things that you know are going to reflect a specific diagnosis, but your job is to listen and try to figure that out.
Yeah, I mean, a lot of times I'm listening to a patient talk and I'm kind of have like a checklist in my head. And I mean, this is prior to even seeing their laboratory. Patient will leave their visit and I will think, this is a low thyroid patient. Like, there's no doubt in my mind. And it's not because I'm smart at all. We've allowed ourselves in our type of medicine to spend 45 minutes to an hour with each patient. So when you have that time with a patient, you actually really can listen and hear them. And, you know, the conventional system is burdened by these compressed visits, 40 patients a day, tons of paperwork that's required by the insurance companies, arguing with insurance companies. So when you have a compressed visit to 10 minutes, how on God's green earth are you getting through all of that patient's problem list and actually hearing them? Instead, you're sitting and charting. And I know because I was burdened by this. I used to do this. And it's an unfortunate fact, you know. So I would tell a patient to be their own advocate. You are your best advocate. Go in with knowledge. A lot of times patients have taught me things, you know. Patients have said, hey, you need to check this too, please. Or I have a feeling it's this. And I really believe in a person's intuition. You know, a lot of times if a patient says, I have a feeling it's something, I'd say 90% of the time they're correct. So you really should be listening. I think that's the number one key in a good patient to doctor relationship. So we'd be remiss to not talk about reverse T3 as well, which is never checked, like never. So, okay, so the top thyroid labs you're going to want. So just somebody who's listening, who's thinking, you know what, I have a doctor appointment in a week. I kind of want this looked at in depth. These are the labs I would recommend. TSH, T4, but a free T4, a free T3. Free meaning they're not bound, and so they're actively available to do the job that they're supposed to do. That's the best way to describe a free. And then reverse T3, which also comes from T4, but it's a different enzyme that pushes it that way. It's D3, whereas T4 to T3, the active form is D1 and D2. So it's a different enzymatic pathway. And a lot of times you'll see these elevations in reverse T3 in general due to stressors. So lack of sleep, I'll see it, environmental stressors, that will raise this reverse T3. And the reverse T3 being a blocker of thyroid, if you have essentially we call it a T3 to reverse T3 ratio that's very low, then that means you have way too much reverse T3. So you have the blocker, too much of it. So you could have all the other numbers pretty much normal, you know, TSH, T4, T3, and you will be low thyroid because you have an elevated reverse T3.
Interesting.
It should be checked.
So what's you have here, one of the things we want to talk about, what's an optimal ratio of free T3 to reverse T3?
Would be 10 to 20.
10 to 20 to
10
1.
to 20,
okay.
Yeah. That would be an optimal ratio. And, you know, this is going to be the tough part is that when you see your doctor and you request these labs, they might kind of say, you don't need that. You know, they might kind of push you up. You as the patient have the right to say, well, I want it. And please order that for me. You have the right to say that. Now, the interpretation of those labs, I'm going to prep you for this, may be difficult for these doctors because none of us were trained this way. Most functional medicine doctors or what we do for a living, we kind of had to do additional training and learn this because it wasn't taught conventionally in medical school or residency. So just be prepared. There might be an interpretation, gap of knowledge for your doctor, but you go in with the knowledge of where it should be. And I will tell you that those reference ranges, and this is, something we mentioned on the last podcast, those reference ranges are based on the population, Quest and LabCorp, those reference ranges that are next to each one of your lab values, they're based on the population. The majority of people who are getting their labs drawn are usually older and usually sick. They're complaining of something. So with that being said, you want to be in the upper part of that range, and for T3 at least, I can speak for that. So the range is 2.3 to 4.2. I'm very happy when someone's sitting at 4, and all the other numbers are in perfect range.
And we went to a lecture here recently, and it was a physician who was lecturing specifically on T3, and one of the take-home points that she had mentioned is that the T3 level that we typically check is in folks typically in older adults.
Yeah.
And so our reference range of 2.5 to 4.2, the average age of those patients might be 70. One of the things that I think she had mentioned is that the average T3 in a kid might be up around 6 or 7.
Yeah.
That's not to say that you're going to drive our patients to T3s of 6 or 7, but it's just because they might start having some symptoms of hyperthyroidism. But it's just an understanding that, hey, if we get that patient near 4 or 4.2 or 4.5 with the T3 and they're feeling good and there are no adverse side effects and they're losing weight, their cognitive function has improved, their energy level has improved, their overall outlook on life has improved, their skin looks better, we'll keep them at 4.5. We're using labs as a reference, but we're treating the patient. And the patient's telling us, hey, I feel better and there are no side effects, then that is a good level typically for that patient.
Right, right.
So one other thing, just to not go into too much detail, but some of the cofactors and some of the mediators that are involved in thyroid physiology were, I think we had talked a little bit about these before, but I think we had talked about selenium, we had talked about iodine, and we had talked about tyrosine. And I know we hit on this a little bit in the first episode, but one of the functions of an enzyme called thyroid peroxidase is to convert what's called thyroglobulin into diiodine tyrosine and then monoiodide tyrosine. Okay, so that's a iodine with a tyrosine. And so you need iodine, you need tyrosine. One of the things that we check in our lab is something called an MTHFR, which is an enzyme that when you take in B vitamins adds what's called a methyl group to those B vitamins. And that serves as a precursor to tyrosine. So if you're deficient in that enzyme, and as much as 50% of the population can be deficient somewhat in that enzyme, then you can't effectively make tyrosine, which means you're going to have trouble effectively making both T3 and T4. So this is just one additional thing, and the treatment for it's easy. It's over-the-counter methylated B vitamins. So this is just one of the things that we check in our clinic, in our functional medicine clinic, to kind of check all the boxes and make sure that we're optimizing that thyroid function.
We should really do an entire podcast
on
on
the MTHFR.
MTHFR.
I find Dana White with the UFC kind of hit the nail on the head with that. It turned out he was actually homozygous for what's called the 677 mutation for MTHFR. So he was able to methylate his B vitamins at 30% of the rate of the general population, and he was having issues with depression, anxiety, weight gain, high blood pressure, and he started taking methylated B vitamins, and a lot of his symptoms improved. And so it's an easy fix, and it's something that I think oftentimes we might overlook, particularly in the conventional setting. So, okay, so just as a summary of the last 2 episodes, what would you say are the big 3 or 4 take-home points for our patients to kind of whether they go to the functional medicine doctor or the conventional medicine doctor to make sure that we're addressing their thyroid needs?
First would be, I really think symptoms matter. Pay attention to symptoms, be an advocate for yourself, know what low thyroid symptoms are, know that those reference ranges don't necessarily reference what's optimal. So be very, very conscious of that. And you're going to have to work with your doctor with this. Not all doctors are functionally trained. And so you're going to have to be sort of an educational piece for them. Other things with thyroid is that it's very treatable. My gosh, it's treatable, and you'll feel so much better. So I mean, ultimately making sure you have a very full thyroid lab and that you're able to interpret it or have a doctor that will work with you in interpreting it.
Awesome. So great episode. So if you have any questions, please visit us at rbikonciergemedicine.com. or come see us at Regenerative Biologics Institute in Vero Beach. We'd love to have you.
Thank you.
Great episode. Thank you.
Thank you.